I've just become so tired of international development programs that were based on good intentions, but just really didn't know if they were working. People who are poor, they have to take the bus, they're coming from long distances, they have to care for their kids. To add like an additional burden to them just felt like so disrespectful.
How do we fill the mental health skills gap? We first had to show that there was a gap. The evidence around mental health challenges in young people living with HIV was actually really stark. We had to show that they were indeed effective and they had a clinically significant impact. For people to really, sit up and think, okay, we should be investing and supporting in the systems and the financing for young peer counsellors.
Being able to help identify and then train people who are coming from that like non-traditional space and who probably didn't have the opportunity to study a 4 or 6-year degree in psychology. I can say with confidence, 71% of people end our program with mild or no depression. And again, that's with community-based facilitators. And so that's what makes it scalable.
Welcome to Mind the Gap, a podcast about what's missing in global mental health.
I'm Christy Savetta.
I'm Chris Underhill.
And we're here to explore the stories, solutions, and systems shaping mental health around the world.
From community champions to global change makers.
Let's dive into what's working and what's not.
And what it'll take to close the gap. Welcome to the podcast. We are delighted to have Nicola and Joy with us here today to talk about their respective organizations and approaches to bridging the mental health skill gap. Nicola and Joy, welcome.
Thank you.
Thanks so much, Chris. Thanks, Christy. Really nice to be here.
We are super excited that you guys can join us today. And we have so much we're going to talk about, and we're going to talk a little bit about what we're going to talk about in just a minute. But before we even get there, I'd love to hear a bit more about the both of you. So Nicola, let's start with you, if you don't mind. Can you give us a quick intro of who you are and share a little bit about, Zvandiri, just kind of light touch?
I'm a pediatric adolescent HIV nurse specialist by training. I've been working in the field for 25 years. And in that time, I've always had a really keen interest in the role of mental health in how we improve health outcomes in children and adolescents growing up with HIV. So that's really been the focus of my work. I've lived and worked in Zimbabwe for 21 of those years, where I founded the Zvandiri program with young people living with HIV. And that's what I've been doing over the years. So at Zvandiri, we train young people living with HIV as peer counsellors, and we connect them with other kids growing up with HIV so that they survive and thrive.
Amazing. I can't wait to dig into the model a little bit more and understand how it's all working together. Joy, over to you. Could you also introduce yourself and Vida Plena?
Nicola, my background is in social work, and I've been living and working in Latin America on the other side of the world, going on 18 years, and the last 13 of those have been in Ecuador. And I originally came to Ecuador because I was running a fair trade company. We worked with women who made handmade jewelry. And I was excited about livelihoods because I wanted to help people have a fair income and good work life. And that did happen. The thing that just kept coming back around was that money doesn't fix everything. And so part of that was seeing the need for, because of my background in mental health, specifically within the social work space, was just like seeing like, how do I connect people to that? And so eventually that led just through great examples of organizations such as the Friendship Bench and Sangath in Goa, just really seeing the need for a community-based mental health program. And so that led to the founding of Vida Plena, which means a flourishing life in Spanish. And we use group interpersonal therapy, which is the top recommendation from the World Health Organization to treat depression in low recourse settings. And get into a bit more broadly what that is a group therapy, and we're working to serve people who would otherwise have no access to care here in Ecuador with ambitions to be able to scale throughout Latin America.
That's amazing. And what strikes me most about this at the moment, just before we even get in, is there's so much richness in how you've started both of your organizations. What's powerful is that neither Zvandiri nor Vida Plena started from a policy blueprint, right? You built it based off of something because you saw there was a need that wasn't being met, and you went out and you figured out what is the tool that's going to work here and in this area. So for me, I really think that brings us to the core of today's conversation, like what it really takes to fill the mental health skills gap, both responsibly and at scale, and in response to massive needs.
Yes, and that's really what Mind the Gap is all about, spotlighting what sits between where we are now and the systems that we need, especially in mental health. Look, let's dive in and get into some of the models and some of the ways of working. You both started in response to deep gaps in care, but the challenge doesn't stop at starting, as it were. Scaling, especially in context with few trained professionals, brings its own set of hurdles. What first motivated you to create Zvandiri and Vida Plena? How did your own leadership journey shape the way these models were built? I wonder, Joy, whether you'd like to jump in first on that one.
Yeah. So kind of, I alluded to this starting. So I was working with Quechua women. They made Joy, and we had this one particular woman who was working with us, and unfortunately, her husband had died from suicide. And because of my background, I was like, okay, we need to get you and your kids help. We need to be able to see a therapist. And I spent a lot of time like trying to make a lot of calls and found somebody who was like, she and her kids could go see. And I wasn't able to. And there's just the distance was too far, the costs were much too high. And became like, it felt like such a point of failure. And then over the coming years, just continuing to see her family struggle and her kids struggle in really significant ways. And it just felt like such a failure. And so it's kind of coming from that, seeing that personal story of her. And so that's kind of, and then I was kind of like on this journey internally of like, okay, I want to do something that's more impactful. And I also want to do something, I just become so tired of international development programs that were based on good intentions, but just really didn't know if they were working. And so I just had seen over and over again these programs that were just, I felt it just kind of hard not to be like, we're wasting people's time. And we're, especially people who are poor, they have to take the bus, they're coming from long distances, they have to care for their kids, they don't have all the conveniences that somebody maybe from like a middle class life in the West might have. Like there's just a lot of challenges that they're already facing. And then to add like an additional burden to them just felt like so disrespectful. So yeah, like I mentioned, I was exceptionally inspired by organizations like the Friendship Bench because of the actual evidence, the years and years of research, academic papers that demonstrated they had really thought very carefully about their impact, and they were measuring impacts. And similar to Sandgath is like just their commitment to rigorous research. And I realized like there was no organization that was doing that really at scale in Latin America. That felt like the first gap. And so thinking back, like just this place that had become my home for so long, I was like, okay, somebody needs to be doing this. And so, jumping forward a few years, after founding Vida Plena, one of like the most gratifying moments was I reconnected with my old team at the artisan workshop, and that woman, she approached me again, like talking about some of the struggles her daughter was having, and it was truly one of the most gratifying moments of my life. We had begun working in her area to be like, yeah, actually, I can get your daughter help, and being able to connect her to somebody who was able to provide that help, and then even jumping forward like 6 months later, just like meeting up with them again, and her and her daughter talking about how much healing that had happened and how their relationship had changed and how the trajectory of her daughter's life had changed. It's like seeing that, and that was kind of like those kinds of needs, and like seeing those spaces that were missing, and then hearing those stories of people. It's kind of really it's what I'm trying to do. And so it's challenging. It's definitely challenging work, but it's like exceptionally fun to get to be part of as well.
Thanks very much indeed. And what about you, Nicola? Do you want to come in at this point? That would be really good to hear from you.
Yeah, so as I said, I'm a pediatric HIV nurse, and I was, started working in Harare at a very exciting time for people living with HIV in that ARVs, the antiretroviral medicines, were just becoming available. There was not so much known about how to treat children, so that was the focus that I was working on, and helping to set up a pediatric adolescent HIV clinic. So these medicines were like a game changer at that time. But what was interesting is that, we were starting children on these treatments, but it was actually a young lady, she was 14 years old at the time, Zimbabwe, and 6 other young people, they were my patients, and they said, it's great that we've got the medicines, but we need more than medicine if we're going to grow up living with HIV, and really live happy, healthy, fulfilled lives like any other child. And so that got me thinking, and it really appealed to my really keen interest in looking holistically at what young people need when they're living with a chronic condition. What else do we need to put in place to support their mental health so that they really thrive? And what was also really exciting is that these young people wanted to be part of the solution. I mean, they were phenomenal young people with lived experience. They knew exactly what their peers would need. So how could we harness that, and give them the opportunity to be part of this, support that we give young people to complement the medicine that they were getting from the clinics. So we started with one support group in my garden. They named it Zvandiri, which means as I am, and we were working with amazing other nurses and counselors who were all volunteering. And we were really just finding our way, learning right from the beginning, of what young people needed. So learning from them, finding our way. We started with one support group that grew into lots of groups. And right from the beginning, the idea was that we complement government and what they were doing as a national health HIV treatment program. So the groups were integrated as a sort of psychosocial support component to HIV care and treatment. But it was about 4 or 5 years later, we still saw that young people were not taking their treatment, despite having these medicines available. And what young people were living with, it was profound multiple losses and grief, often unresolved, not talked about, profound stigma, discrimination in their homes, in their communities, in their schools, in clinics, the fear of their own mortality, fear of what was going to be ahead, fear of others finding out their HIV status, isolation, not knowing anyone else in their situation. And all of this was obviously having such a profound impact on their mental health. And it was the mental health that is driving their poor outcomes in terms of their engagement in care and the medication. So right from the beginning, young people have told us that's what they need. They need mental health integrated in their treatment, and they wanted to be a part of it. So we train young people as peer counselors, and connect them with other kids living with HIV.
It's incredible. I've known you both. I've had the pleasure to know you both for years. That might be exaggerating a little bit, for a long time now. And you both have such incredible, founding stories of your organization. Every time I hear them, I just get inspired all over again. So thank you for sharing both of those backgrounds. It's really helpful to understand where you started from. And one thing that really jumps out, we talked about a bit at the beginning, is, you're both working in settings where mental health need is obviously very high for different reasons, of course. But it seems like specialist resources and access to care are scarce. And I think, Joy, your story at the beginning really puts that to a head. You couldn't find anybody, right, to support this moment. So, one of the things that we really want to get into is how have you actually approached filling this mental health skills gap, especially when it comes to thinking about delivering services at scale. And you guys both have started to allude to it a little bit, but I'd love to get into the nitty-gritty a bit more. So Joy, over to you. Do you want to kick us off?
Yeah. So specifically, like I mentioned, we use group interpersonal therapy, and it is the version that was developed by the WHO in collaboration with the Columbia University Global Mental Health Lab, specifically Lena and Brian over there have been developed this really cool version that's the jargon called task shifting. And so for those who are familiar, basically what it means is you're training non-specialists, kind of paraprofessionals to be able to, in our case, lead these group therapies. And so we kind of, to do that, what we've really kind of dug in on that model. So we started in Quito, which is the capital of Ecuador, and now we're working also in a new region. It's the province of Zimbabwe, which is much more rural. It's much more, it has a higher concentration of indigenous people, specifically Quechua speakers. And so when we did that, we very intentionally chose people who can come from the Quechua community. They live and work in the communities where they're serving, so they really deeply understand. But because we weren't really relying on things such as traditional degrees of psychology or other mental health degrees, we had to kind of come up with a way to be able to identify people. And I just always like to kind of share how did we do that? So we kind of put out a call for people to be able to be trained with us as facilitators. And then we went through sort of a multi-step process in being able to identify people. And one of the first things that we had people do was we had an initial round of selecting, and then we sent people a small homework, which was they had to watch a Pixar short of these little birds. They're kind of fighting, and there's no words. And then we had people respond. We had them set those the audio, WhatsApp audio messages, and just kind of analyzing the situation. So what we were looking for is we were looking for people specifically who had a high degree of emotional intelligence, a lot of empathy. They're able to understand both sides of the stories, and just looking for how they're able to articulate their thoughts and feelings. And so the reason we're doing that is because we really wanted to be able to focus on people who didn't have formal training, but really just have this innate caring, this innate sense of just like I said, emotional intelligence and strong communication skills. And so with that, we were able to find a really exceptional group of people who did demonstrate that. And so that's kind of what we're betting on. We're on year 3 right now. And so what that looks like is really being able to help identify and then train. We are very rigorous in our training and supervision, but people who are coming from that non-traditional space and who probably didn't have the opportunity to study a 4 or 6-year degree in psychology. And so but it's been really exceptional because what we do is we do going back, we track very rigorously the outcomes of all of our participants who are going through the program. And so I can say with confidence that 71% of people end our program with mild or no depression. And again, that's with community-based facilitators. And so that's what makes it scalable. It's working in this group setting and then working with people who are actually based in the communities, because as we start to work in more and more rural areas, there isn't a psychologist. And so who can be that person with the proper training and supervision who can step into that gap?
That's incredible. And it's wonderful for you to kind of bring in those outcomes that you've been seeing as well. And you're in great company, right? In terms of, a lot of the task shifting and that being a big part of this push towards community mental health. And Nicola, of course, you mentioned that, young people at the heart of delivery kind of being those community-based facilitators, for instance, in the Vida Plena model, but for Zvandiri. Can you share a little bit more about the approach that you take with these young people as facilitators and kind of why them and what it looks like to kind of bring them on board?
Yeah. Well, I'll start with, in terms of how we've approached this, I would say slowly and carefully. This has been sort of 21 years of learning from young people what they need, how we could develop co-creating services that are responsive to their needs. And what we had to do is really, you talked about, how do we fill the mental health skills gap? We first had to show that there was a gap. Because mental health, the evidence around mental health challenges in young people living with HIV was actually really stark. And we had to prove, firstly, that there was a gap. And then we had to prove that young people, our peer counselors are 18 to 24 years old. So we had to show that they were indeed effective and they had a clinically significant impact. For people to really, sit up and think, okay, we should be investing and supporting in the systems and the financing for young peer counselors. And so that's all to say that we had to do a lot of evidence generation, and whether that was really careful program learning or more formal research studies, formative studies, and evaluation studies. And we found that young adolescents living with HIV in Zvandiri had a 60% reduction in symptoms of depression and anxiety. We also found that they're much more likely to do better on treatment and less likely to die. So a lot of evidence. And how we've approached this is, as I said, learning from young people, listening to what they need, and then developing this peer-led approach to supporting their peers' mental health and well-being. And so the peer counselors are integrated within the national health system. They're based in clinics. They're supervised by a clinic nurse or counselor, by a professional nurse or counselor, and they are allocated a caseload of other kids with HIV. And so they support them on a monthly basis in the clinic, in their homes, through support groups, and by phone with digital platforms. So I can talk more about that in a moment.
Thank you very much indeed. I wanted to prompt you, Joy, just very briefly. You had a story to tell about Liz, is that right?
Sure. So Liz is one of our group facilitators. By background, she works with her training previously was working with elementary school kids, and so she joined our team back when we started working in Zimbabwe in October. And initially, we had a little bit of hesitation, and she seemed like very quiet and timid. But we saw kind of like deep this deep strength in her also, and it's just been really exciting to see really remarkable to see how she has just like grown and transformed. And so over the past months, and how she has become one of the strongest facilitators on our team. And I say that specifically in terms of the results that she has with the people in her groups. She kind of likes to tell this story sort of like kind of laughingly, but then it's just kind of an evidence of like the impact she's having. So there's a woman in her group, and when the first started showing up, she would come in her pajamas. She was very like, just clearly like very deeply depressed. And then over the 8 weeks that the group met, like this woman changed so much that it became clear like how she was caring for herself, and she was like showering, and she'd show up to her group sessions like dressed and like well put together, and so much so that this woman's husband started to be like, who are you seeing? Are you cheating on me? What's going on? It was just like representations. Like kind of Liz tells the story is kind of like she finds it so amusing that like this woman changed so much that her husband was like, what's happening? Something's going wrong. We can't just be better, and there has to be something else. And it's like showing those people that like finding that kind of like people. There's so many people who want to step in, and then just like giving them the opportunities. And so just kind of like a small anecdote about her. And then also I just want to share another one, just kind of again about like the power of group therapy and why we do that. When we were starting in Quito, we worked with a different facilitator who was a young college student who was studying psychology, but is only in his second year. So pretty young, but just showed a lot of like promise and talent. So we trained him in the model. He became certified by Columbia. And the first group that he had, just by kind of like the demographics of like who signed up for that neighborhood in that time slot, it was all middle-aged ladies with marital problems. And since supervisors were initially like, oh no, like how are we going to manage? I don't know. He's probably not like maybe we should switch it because he's this 23-year-old young man, and these middle-aged women, they're going to look at him and be like, what life experience do you have to be able to tell me? And he didn't have any life experience. He doesn't have that kind of life experience. But what he really did, he did a wonderful job of creating a space where the women were able to share with one another, and they were able to guide one another through their problems. So he did a really wonderful job of creating that space. And that really is the power of group therapy, specifically why we use group therapy. It was really, he created that space and was able to guide through the questions he asked and like the activities that they did, really bring those women together so that they were able to support one another through their marital problems and be able to grow and help each other. And so just kind of a few small stories about the facilitators and the exceptional work that they do.
Thank you very much indeed. It's clear that the programs are having an effect, and that obviously task shifting is working. I just wanted to remind listeners what task shifting is, just to be clear. So for listeners not familiar with our jargon, task shifting really means moving care delivery to people who may not have formal degrees, but have the skills and supervision to deliver it well. And in both cases, we've had wonderful examples of that. I wondered whether, Nicola, we could come to you now just to elaborate a little bit further on this question of task shifting and how you have developed it.
The young people, George has been speaking about this. I mean, the phenomenal work that lay counsellors are able to do. The peer counsellors that we work with are fabulous counsellors. They come with their own lived experience. They're deeply empathic. They are experts in their own right around HIV and mental health. What we do is really equip them with evidence-based tools and approaches so that they can apply this in a therapeutic way for their peers. But what I really want to emphasize in terms of scaling is they do wonderful work, but they cannot be asked to operate in a vacuum. And I can't emphasize enough the importance of system strengthening. So building a system for these young peer counselors, and I'm sure older peer counselors, to work within. And so that's really been our focus over 2 decades of working with government to make sure, yes, that we are developing evidence-based tools and approaches and upskilling the young people, but that we are putting in the systems that recognize and value and support them to do their work. So this is across multiple different domains. So starting with government leadership and coordination, ensuring that there's a clear understanding of the role, clear expectations, and real national, provincial, district buy-in for the work of these young people. Otherwise, the risk is that they are, we're running parallel programs as an NGO. And so what we found by really working with government is they have a really sustainable approach. The government of Zimbabwe is paying for this CARDA in select districts and really in recognizing and investing in young people. We also need to invest in capacity building healthcare workers and communities, families, so that they too know and understand the role of young people in these roles. And particularly on child and adolescent mental health. We kind of seen that adult approaches are applicable for children and young people. But there's, really been a lot of our work has been around ensuring that the environment within which peer counselors are operating and doing their work really understands their role and what they're trying to achieve. We need evidence-based training and guidelines and tools for young people, again, that are really focused on children and adolescents. We've developed a lot of, colorful, interactive, engaging, child-friendly approaches so that they really do have the tools that they need to engage and counsel and support their peers. We need clear referral pathways so that when young people are identifying challenges that young people face, that they know clearly what they can manage, but also how to then onward refer their clients for other services. And what I really want to emphasize is supervision. That we're often asked, people are interested in training a group of peer counselors and sort of have this idea that it's a short-term training and off they go. But we really need to be advocating to governments, to implementers, service providers, funders. One of the key investments in these models is supervision, and that the training is just the beginning. And we need the systems in place to ensure that supervision is done and delivered and sustained for young people. And then I think finally, monitoring and evaluation. We need systems that recognize the incredible work that these young people are doing. We report on the clinical outcomes of people with depression, whether it's depression diagnoses or the numbers treated or those with a suppressed viral load in the HIV world. But we often don't have the systems that recognize the fact that our peer counselors have walked or biked to go and visit those young people, spend hours counseling around really complex situations, working with caregivers, supporting healthcare workers to achieve those improved outcomes. So we work closely with our Ministry of Health to ensure that specific indicators are included, they're tracked, that we collect the data, and not that we just collect the data, but then we analyze it and use it to really recognize the powerful contribution of young people.
Thanks very much, Nicola. One of the things that struck me about the way in which both of you presented today is that is the need for supervision and the way that supervision is a thread that runs through both of your approaches. I'd like to jump us down to that now and ask you whether you would be happy to talk about what good supervision actually looks like, especially when working with peer or community-based providers. And how do you measure whether someone truly has the skills needed in relation to that supervision skill? Joy, let me ask you to come first to that, if you would. Thanks a lot.
Sure. So we're a much younger organization. We're currently in our third year. And so right now, all of our supervisors were trained and directly certified by the Columbia University team. But now we're kind of starting to think about like, what does that next generation of supervisors look like? And then specifically because some of our facilitators have been doing this now for 3 years with us, we're thinking about like, how can they be trained up to become supervisors themselves? And also, we're also working on expanding through government partnerships. And so, for example, we've trained 30 people now through the city of Quito. And so our team is providing the direct supervision for that, but it's like, okay, as we like that's a kind of the limit of what we can do. So that it's like, as we go to the next phase, who can be those supervisors? And so we kind of been looking at that from different phases. We're working on a partnership with the University of Southern Utah to start creating that supervisor training program alongside with Columbia University. And one of the things we've decided is we really need to understand, like, what does supervision look like in our local context? Just like small example, like I'm American, and so I come in like all of my leadership style is very like collaborative and working kind of like with the team and kind of self like learning together is kind of my approach. And I've been occasionally given the feedback that some people in our context might see that as weak, like when I'm asking the team for their feedback and their thoughts, whereas because like often here there's a lot of hierarchical nature of like how organizations are run. And so it's like knowing that and understanding that, it's like, okay, how do we like then adapt our supervision so like we're able to provide feedback thoughtfully, but in a way that people will take it as like respectful, and kind of having those like feedback loops. And so, but like just kind of broadly, like what we do right now for supervision is every single one of our facilitators, they meet weekly with a clinical psychologist who has been certified in interpersonal therapy to be able to go over their cases. We're very careful in how we think about case escalation for people who are in need of more in-depth care, specifically people who are high suicide risk. And those are things that are really important. I think like as like Nicola said, there's so many people who are like, oh, can you train us in the model? And it's like a pretty fast training. It's 2 weeks. But really where the learning happens and like the deep understanding of like how to do the model and how to do careful actual application and run the groups does come in the weekly supervision, because that's when people are able to get into their cases and talk about what's happening with their specific individuals that they're working with, and they're able to discuss like the difficult challenges that they're coming up against. And understanding that what supervision looks like is so important. And also part of that, I'll just like add on, is like caring for the peer, your counselors, in our case, we call the group facilitators, caring for them emotionally, because they're carrying people's like deep, difficult stories. And there's a lot of like, you think about a lot about like vicarious trauma. And I think that is something that's like really important. It's not just like training people and throwing them out there, but like if they're going to be like hearing people's difficult stories, it's like, how do you help them so that they don't become burnt out? And I'm pretty proud to say that we have so far in our first 3 years, almost no turnover. And I think that is because we've really invested a lot of time and energy into caring for the facilitators as they're walking alongside our participants.
Thank you for that, Joy. That's really interesting and very helpful to have that in-depth explanation. Nicola, supervision has been a critical part of Zvandiri's scale-up approach. And you've obviously built it into your system as the organization has developed. Perhaps give us a sense of what good looks like.
I want to first just call out the distinction between administrative supervision and clinical, and I'll focus on clinical supervision. But I think from my perspective of overseeing this program, funded by donors with funding reporting requirements, etc., and suddenly you can find you've got 1,100 peer counselors with a lot of administrative work to do, which, if you're not careful, can take your efforts and focus away from the clinical supervision. So I think that that's just been a real learning curve for us, because we really want to focus on the clinical supervision, while of course also not ignoring on the administrative side, where they're having to, making sure that they're working in line with organizational policies, providing the documentation that we need or funders need, etc. But from a clinical supervision role, we've really, from the outset, looked at whatever we do needs to be scalable. We have 55,000 kids in Zimbabwe supported at the moment. How do we ensure that their peer counselors are all receiving quality clinical supervision at scale? Our model, young people are supported over many years. So it isn't a set number of sessions over a short period. So we also have to look at how do we sustain this supervision. So the first thing is to have really clear guidelines and clearly defined competencies, skills and competencies that we're looking for. And that's, of course, linked to their initial training, but linked to the scope of work that we're asking of these young people. So we have clearly defined guidelines, competencies, and supervisors. So for us, the healthcare workers, government healthcare workers, are the supervisors. We provide technical support and mentorship, but they are the ones delivering the supervision based in the clinics. We have integrated EQUIP because we wanted a sort of structured approach to measuring, assessing counseling competencies among young people. So we use EQUIP and ENACT from a pediatric perspective, and we are finding that really helpful. It also, from an advocacy perspective, confirms that these young people are acquiring counseling skills just like adults are expected to do. So that's been really great to see. And then we deliver a hybrid. So it's a hybrid between in-person supervision by the counsellor or the nurse in the clinic, but also using digital platforms. So we use a combination of WhatsApp groups they find really, really helpful. Echo, so digital online echo sessions where we discuss cases and young people share their own experiences, challenges, lessons learnt, and we're able to input into supporting, strengthening their skills and competencies. We have tablets based in facilities where there's additional information and modules that they can work through. What else? We have Zvandiri Connect is our CompCare-based platform. And we we're excited to say, just developed a chatbot, which is really interactive, obviously. So the peer counselors will counsel clients on the chatbot, again, coaching them as they strengthen their counseling skills. So there's been a range of in-person and digital approaches to this.
Thank you.
So you're really looking at, how do you make supervision almost accessible and usable to all of the different types of folks that you're engaging with, and in different ways. So you're covering like a whole range of services and support for these young people, as well as Joy for you for the lay providers that you're working with. I mean, you both touched so much on these incredible systems essentially that you've built, right? These tools, the training, the supervision. But one big question, and Nicola, you start to talk about it a little bit, is how do you actually sustain all of this? And it wouldn't be Mind the Gap if we didn't talk about funding. So one of the big questions is talking a little bit about funding, and especially as we know in the mental health sector, there's a massive gap in terms of global development funding for mental health, as well as, of course, government funding for mental health. So I'd be curious, and Nicola, let's start with you if you don't mind. What are you seeing in terms of government interest or willingness to fund mental health services? What is there? What's still missing when it comes to these types of things? And do you have any thoughts about how we can make some of this stuff like sustainable and scalable?
As I've been saying, our approach has been that we should be working ourselves out of a job. This is government delivered and government financed. And so from the outset, as I said, we needed to demonstrate that this was needed and effective. In our case, we needed to demonstrate the strong correlation between mental health and HIV. And that helped us to secure funding from an HIV sector, but also a mental health sector. It's been about ensuring that we support government to establish the systems. In Zimbabwe, we found tremendous leadership for this approach. There's huge investment in a peer-led model to improve the mental health of young people living with HIV and those not living with HIV. We have developed a government-led framework. We call it Thrive 95, with a focus on young people thriving with 95% viral suppression. We've developed this with our government, with WHO and UNICEF, and this is a standards-driven system strengthening framework to support governments to put in these systems to really ensure that this approach is scaled and sustained for all young people. It's got 8 pillars, and one of the pillars is very much focused on financing. And we're really proud to say that Zimbabwe has, for 4 or 5 years, as I said earlier, been paying for this model. They're directly financing it using domestic funds. Many other governments are wanting to learn from this. So 14 other countries have adopted, localized the Zvandiri model in their own context, led by government, with young people at the forefront of this throughout. And actually, just going back to supervision, I didn't say, but many of the young people, and in fact, my first patients, are now employed in Zvandiri and actually supporting other governments to establish this model, providing supervision for other young people in other countries, which is joyous to see. It's really about giving government the tools to establish these systems and demonstrate that domestic financing is feasible. Obviously, it's a very tricky time, and there are many, many priorities, but we have some really fabulous best practices where governments, so Zimbabwe and now other countries, are starting to emulate that domestic financing for peer counselors supporting mental health. And we've also completed a cost effectiveness study that shows if you invest in young people, you support them with the skills and the tools that they need and the system within which they work in, this model is highly cost effective.
Amazing. And surely, I mean, like the Zvandiri's kind of your approach around domestic financing and the work you put into it it's a very cool beacon within the sector. I mean, there are organizations that have done it. And it's great to see you all doing so as well. And I know, Joy, you guys are 3 years compared to Zvandiri's 20, but I'd love to get your perspective as well in terms of what does it look like? How are you thinking about scale, and how are you thinking about funding and potentially domestic financing at some point if that's part of the pathway?
Yeah, just also briefly, we have a partnership with right now the city of Quito, and like I said, there's 30 people that we have trained, and then we're kind of doing a joint model in which we provided the training and the ongoing supervision, but they continue to be on the payroll for the city with the health department, and so kind of like this, like really, it's like this also kind of like great collaborative model, and like clearly the city is putting effort and resources, in fact, that they're financing these salaries and then like kind of all of the administrative pieces, but then we're able to help jump in with the technical support because these they were doing sort of like one-off workshops. They weren't doing any sort of like sustainable therapeutic process, and they were doing zero results based impact based measurement there. Everything was all about outputs. And so what we've been having them do is to like think more deeply about like what are the impacts they want to be doing, not just reporting on like number of sessions provided, but like are people improving as a result long term. And so it's been exciting to see that there's that sort of interest. And I think that's kind of like our pathway forward is Vida Plena providing that sort of technical assistance to then the government will implement within their kind of mandate. So that's why kind of like the vision of what we have in terms of scaling and being able to partner, hopefully long term, with the nationwide Ministry of Health.
That's incredible.
Yeah,
it really is amazing. And just to kind of like, I think your organizations are fantastic examples of pointing back to kind of our first podcast, which we actually just recorded only a few weeks ago with 2 wonderful folks who did a massive deep dive in research into like how to scale with and in partnership with government, and thinking a little bit about like what is honestly, it can be a very messy but exciting and long-term sustainable strategy. So it's very cool to kind of follow that up with this and to hear the examples from both of you in terms of how you're thinking about and your organizations are thinking about this long-term work and this deep partnership with the Ministry of Health and the ministries in general. So thank you for that. And it's really helpful to kind of pull those threads together. Chris, over to you.
Thank you very much. Well, sad to say, we're getting to the end of the session. And I must say the time has gone really fast, and I've learned a lot in this process. Thank you so much, both of you. Just to pull out a couple of thoughts from the discussion that we've had to date. I think, first of all, what's been really significant and really helpful and delightful is just to learn a little bit about your backgrounds, both of you, how you came to the work in the first place, which is, and of course, each has their own story, but their leadership stories in the end, which are, I think, rather fabulous. And how, of course, you came across the issue of mental health and how you wanted to apply skills in mental health to your own settings and to the vision that you then developed. And indeed, vision is a very important part of this, because both organizations, whilst obviously having some characteristics that are the same, also have very clear visions, which I think make them stand out one from the other, whilst at the same time both providing great service. One of them, of course, younger than the other as well in terms of the age of the organization. I love the names of the organizations, As I Am and A Full Life. I mean, it just sort of produces the right feeling, which made me feel so good when you were explaining that. I felt it was important to think about the people who are working for you at whatever level, and whether they come in as staff persons or volunteers or whatever they may be, and how they might be themselves carrying grief, carrying trauma, and how important it was to try to recognize that and to put in place different approaches, having first of all, of course, acknowledged that this was what was going on. And so alongside the growth of the organizations, then comes the growth of the care for the individuals in question, for the staff. And I think that's very important, whether it's across, several project sites in the one case, or whether it's across many sites and a number of countries in the other. I love the way that you seem to believe in your own people. And I think that's, because I have run mental health programs, and so there can be some headaches as well. And so sort of seeing through that and understanding just how much you believed in your own people seemed to me to be, really exciting. And therefore, how you learn from your own people. And that's one of the sort of really important features, it seemed to me, that you were able to turn around what at first might be hierarchical scenarios, or might be managerial or management-based scenarios, and actually in the end have a situation where you are learning from the very people who are at the front line and the people who have a lived experience. And quite often the two come together, and they're the people who are actually doing, your delivery, which of course is important. I could go on further, but I think you can see that I've been listening carefully and really learning and sort of imbibing what it is that you're doing, with just a very few questions from Christy and myself. So all we want to do now, really, Nicola, Joy, is to thank you both very much indeed for having been with us on Mind the Gap. Thank you.